Okay, look, I will get started because we've got lots to get through today. So, good afternoon, everyone, and welcome to the Community Mental Health Drug and Alcohol Research Network's webinar, Knowledge and Practice, Transforming AOD Support Through Collaboration. My name is Katie Sam, and I'm the project coordinator for ComDAN. And I would like to begin today by acknowledging the traditional custodians of the lands of which we're all meeting upon today. I am lucky enough to be working and living and learning on the lands of the Wongal people of the Eora Nation, and I pay my respects to their elders past, present, and emerging, and extend that respect to any First Nations people attending today. I feel incredibly blessed to continue to learn about the unique ways of knowing, being, and doing of our First Nations communities, and in particular in relation to social and emotional well-being. I'd also like to recognise those with lived and living experience of mental health and substance use needs and their important role in leading policy and service reform, particularly through research and evaluation. So, look, thank you so much, everyone, for joining us today. I'm really excited about this session because I think it's going to be really valuable and inspirational for those of us working in the mental health and AOD sectors. I'm thinking of today as a bit more than a presentation. It's a really nice reflection on how evidence and collaboration can drive meaningful change. And before I hand over the reins to the lovely team to run the session, I encourage you all to please use the chat and Q&A functions throughout the session. Everyone is really happy to answer all of your burning questions, so please don't be shy. We're due to finish at 2 o'clock today, and the webinar is being recorded for you to share with your networks. So, look, I'm going to hand over to the lovely Caitlin now to help introduce the session. And yeah, I hope everyone enjoys. Thank you so much, Caitlin.
Thanks, Katie. Thanks everyone for joining. I'm Caitlin. I work with the Salvation Army Alcohol and Other Drug Services as an AOD specialist. And we're joined today by some other members of the Salvation Army AOD team, including Catherine Wright as the General Manager, Liz Edmondson as a fellow AOD specialist, and Penny Chugg as the State Manager for Tasmania. We also are joined today by Dr. Hannah Bereznicki, who is a lecturer at Deakin University and who led the evaluation of our model of care from Deakin's side. If we could go to the next slide, please, Katie. Just wanted to give everyone an idea first of the Salvation Army Alcohol and Other Drug Services. So we are the largest provider of alcohol and other drug services, treatment and support services across Australia. We operate in over 30 locations, as shown on the map there, in all states and territories. There's a range of different services provided, and in each of the locations, there's usually 2 or more of the services provided at that location. To give some more examples of the size, we have over 600 staff members. We provide 591 residential rehab beds, 65 withdrawal beds, and in the financial year 2023 to 24, we provided over 220,000 sessions of care to people for alcohol and other drug and gambling support, which equates to nearly 12,000 people that we assisted in that financial year. Now I'll pass on to Catherine Wright, who will talk about the large task of making a national model of care, speaking to all of those services in those diverse locations. Thanks, Catherine.
Hi, everyone. It's great to be here today. So if we could have the next slide, please, Katie.
Hi, Catherine. Something's up with your mic, I believe.
Okay. How about
perfect. There we
How about now?
Excellent.
Can others hear me now? Okay. Sorry about that. I'll just go back a little bit because I'm not sure how much you missed.
Oh dear, I think it might have
The
happened.
first, can people hear me now?
Yeah, that's better. It's just
It's fine.
going into the content, it's cutting out.
Oh, okay.
Okay,
Just
there
don't move. Okay, I'm going to try and keep my head really still. For the first time ever, all of the Salvation Army AOD services in the country came under one. We've lost you again. How about now? If not, I may have to hand over to one of my team to.
Now.
Yeah, that's fine, Catherine.
I'm on the computer speaker now, so I apologise for any background noise.
That's beautiful.
So in 2019, for the first time, the Salvation Army AOD services across the country came under one management department, and I found myself in charge of that department. The first thing that we noticed was that throughout the country, we had very different approaches to our AOD work, very different practice, very different underlying philosophies. And so we decided that we needed to develop a national model of care that across all service types and all states, we were singing from the same song sheet. So we did that in collaboration with 360 Edge and launched that at the end of 2019. And that's when we started the really hard work of implementing it. And so from that launch onward, we began developing a range of practice documents and frameworks to sit under the model, to help people to translate the model from that nice glossy book that we had to actually what happens on the ground in our services. In 2020, we did some more work around tailoring the model of care to individual service types and locations. And then in 2021, we went a bit deeper again, creating comprehensive service manuals for different treatment types. 2022 came around and we decided that we needed to have a little internal look at how well the model had been implemented across the board. And that had kind of different results in different states. And so we focused in the next year or so on strengthening where it hadn't been strongly implemented. In 2024, we engaged our friends at Deakin University to evaluate the model of care and the implementation of the model of care. And that work was completed early this year. And we're really pleased to present to you today some of the process as well as the findings around that. I'll hand over to whoever's next.
It's me. Thanks so much, Catherine, and thanks for taking the heat with the tech issues. It was bound to happen to one of us. So you've taken the heat off all the subsequent presenters. Thanks for the intro. My name's Hannah. I'm from the Connect Research and Training Initiative at Deakin University School of Psychology, and I led a really large team of researchers within the School of Psychology on the implementation evaluation for the model of care. Next slide, please, Katie. Thank you very much. So this was a huge project. It was very ambitious in the time that we had to complete the implementation evaluation and design and collaborate on it together and then deliver right through to the final outputs. We had 8 core research questions that we wanted to evaluate through this project. So we wanted to assess whether the model of care, which was developed in 2018-2019 by 360 Edge, held up to current best practice evidence now in 2024 at that time. We wanted to see how the model of care positioned the Salvation Army AOD stream with in the broader AOD treatment sector. And we wanted to know how the model of care had been, the national model of care had been communicated to staff and how staff understood the principles and values and frameworks within that model of care. We wanted to know about the rollout and how effective the implementation was and the barriers and the enablers of implementation. And then we wanted to know how the model of care was being translated day to day in practice across different states and territories and services. We weren't done yet. We also wanted to know how participants perceived the impact of the model of care, how staff perceived the impact of the model of care in their own work, but also for participants and stakeholders. And then we wanted to interview stakeholders as well to find out more about their experiences with the model. And then, of course, we wanted to also identify strengths and opportunities to improve the model itself and the model's implementation and how it was being translated into practice. Thanks so much, Katie. Next slide, please. Beautiful. Okay, so I was really keen when we were co-designing this implementation evaluation with the Salvation Army team. We developed a steering committee that included researchers from Deakin, representatives from the Salvation Army AOD stream, and including those with lived experience as well. And then through that steering committee, we discussed the sources of evidence that we would collect and collate so we could synthesize that and recommend, make really practical or synthesize for the findings and then create really practical recommendations. And so that was a key aim of the implementation evaluation. So in the end, we had thousands of data points that we poured over for about 8 or 9 months. And so I thank the huge team from Deakin who contributed their multidisciplinary expertise to really achieve the aims of the implementation evaluation. We based the implementation evaluation on a consolidated framework for implementation research, which looks at the intervention, which in this case was the new national model of care. We looked at the outer settings, so best practice evidence and what was happening in the sector more broadly. We looked at the inner settings, so sort of factors and context relevant to where the model was being implemented and applied. And we looked at the characteristics of individuals, participants, staff, and stakeholders. And we also looked at the process of the rollout to evaluate what worked really well and where improvements could be made for next time. As I said, this was a big project, so it was a national implementation evaluation. So we conducted interviews with staff and service participants and stakeholders all around the country, or that was the aim, to get a really full picture of how the model of care had been implemented, how it was being rolled out, how well people thought it was working, and barriers and enablers to its application. Next slide, please, Katie. Oh, sorry, Katie. Can you go back one? Sorry, my tech issue. Just wanted to run through quickly the sources of evidence. So we conducted individual semi-structured interviews that lasted about 45 minutes to an hour with service participants, with staff, and with stakeholders. We also conducted an online survey with staff to get a broader range of participants than who we could access to interview on how they felt about the model of care, how satisfied they were with it, and how they felt they were applying it in their practice. We also leaned heavily on pre-existing data from participants on their survey exit data, and data from national data from the services themselves. Then we also conducted, to assess the outer setting, we conducted 2 narrative literature reviews, one on AOD models of care and best practice development, and another on the moderators or factors that influence AOD treatment outcomes. And we also conducted two scoping audits as well. So we did a desktop review of documents, practice documents, policy and procedure documents from the Salvation Army, including training materials. And we also conducted a scope of a sector-wide AOD treatment scope on other providers' publicly available models of care to see how the Salvation Army's was either, similar or different. Thanks, Katie. Beautiful. So we, as I said, this was a huge project, and we, ended up with we'll talk about the outputs in a bit, but we ended up with a massive report with lots and lots of findings and then key practical recommendations based on those findings. But I'll just give you a rundown of some of the core findings. So participants reported a high level of satisfaction with AOD services and their experiences. They were confident recommending the services to others, and very encouragingly would re-engage with the services if they needed down the track. Participants in their interviews, service participants in their interviews, gave some really detailed examples of how facets of the model of care, principles and frameworks of the model of care, such as harm reduction, such as person-centered care, such as strengths-based care, had been part of their experience through the services. So that was one way that we could assess. We couldn't directly really ask participants about, the model of care itself, but we could ask them about their experiences and then map those onto the different frameworks and principles and values of the model of care. Staff also perceived the model of care to meet the needs of participants well. One unexpected finding that came out of the implementation evaluation, which we were able to really get a nice, rich picture of because of all of the different sources of evidence that we interrogated, was that participants indicated that spirituality and the faith-based values were a welcome or neutral optional addition. So only 5% of participants in their exit interviews indicated that they disagreed with the spirituality and faith-based aspect of the service. And this sort of positive view of spirituality and faith being an optional addition to services was largely echoed by staff and stakeholders as well. So through interviews and surveys with those different groups, it meant we could sort of create a picture of what it was looking like overall. And this was also sort of mirrored by the scoping review of available models of care of other providers, being that the Salvation Army AOD model of care was publicly available, that faith was really emphasised within that model of care. And those were two of a few factors that really set the Salvation Army AOD streams model of care apart from the sector. As I said, participant feedback of staff was overwhelmingly positive. Participants psychoeducation within their programs, but they reported being really satisfied overall. And participants perceived positive impacts on their health, recovery, skills and connection. And we could glean that from the pre-existing exit survey data, as well as participant interviews as well. Thanks, Katie. For staff, so staff rated their understanding of the model of care values and principles and frameworks as good, but reported that they were seeking more training and support around implementing the model of care in practice, and particularly where they reported particularly where there were complex participant presentations or complex scenarios. That meant there was they really relied on their clinical judgment and ethical decision-making frameworks to resolve, to find a path forward in terms of, complementary frameworks in terms of trauma-informed and harm reduction frameworks. What should they do in a particular complex scenario? And Penny will talk about that a little bit later in the presentation. Thanks, Katie. So this is an example of a couple of the recommendations that we made in the final report. So we could use those evidence sources to triangulate findings and then make really specific practical applied recommendations. So for example, we recommended that the Salvation Army implement a nationwide framework for a phase 2 implementation of the model of care, particularly strengthening those communication pathways from senior leadership to frontline staff and developing a centralised communication and access strategy. So we made some recommendations based on the team's knowledge of AOD policy and implementation science. We were able to make some really specific applied recommendations there and for training as well. Thanks, Katie. I'm to time. I set a timer to make sure I didn't go over, and I did. Sorry. Thanks so much.
Thanks, Hannah. Hi, everyone. My name's Penny. I have a few roles in the Salvation Army AOD program, but for the purpose of this presentation, I'm talking with my Model of Care Coordinator cap on. I'll just run through some of how we've translated some of the findings into our practice. Thanks, Katie. So what have we done with the evaluation? It's not sitting on a shelf somewhere getting dusty. We've had quite a few meetings nationally. We've met with our managers and team leaders to talk about the evaluation findings and to develop a strategy on how we're going to move forward. We've looked really closely at what worked well in the last one and what could be improved. And we've sought a lot of expertise from other specialists within Salvation Army around family violence, people with lived experience, and our First Nations AOD specialists. We've got a meeting with our national leadership team next week to review the draft that we've put together and just workshop some of the ideas and themes. And we're currently undergoing a lived experience recruitment process. We've put out an expression of interest for people with lived experience to come along and to assist us in reviewing some of the materials and providing feedback. And we've also developed some implementation flyers and materials that we've distributed to our stakeholders. Thanks, Katie. So the process, as Hannah's alluded to, this was a huge project and very complex. So there was over 80 recommendations and a lot of feedback, which was all really useful, but it has been quite time consuming to actually sift through it all and sort it and work out what goes where and how that's all going to fit together. So that's where I come in as the dedicated Model of Care Coordinator. And I've been working on categorising and reviewing the recommendations and feedback. So we've developed a phased approach to prioritise the actions and assign responsibilities. So the first phase, which we're in now, is to develop the new model of care. Phase 2 will be implementation and staff development, and they're going to overlap a bit because we're already, even though we're not in phase 2, we're already looking quite carefully about implementation, and Liz will talk about this in a bit more detail. And finally, the last phase will be the ongoing evaluation and some of the bigger picture recommendations around organisational structure and data collection, etc., things that we can't make immediate changes to. Thanks, Katie. So, and again, and Hannah mentioned this, I think the standout for us was the unique integration of chaplaincy and holistic spiritual support. That was really pleasing to us to see that that was acknowledged and that it was seen as to be so important by our staff and our participants. So we're making sure that we keep that the new model, and we're probably going to go even a little bit further. Some of the other recommendations were around cultural safety. I think as an organisation, we do this very well, but we're going to introduce the social emotional wellbeing framework as a new framework in the new model to cater to our First Nations people. And again, Hannah's touched on this, the integrating frameworks. This has been a challenge for staff, how you balance person-centred practice and safety. So being person-centred doesn't mean people get absolutely everything they want and there are no guidelines, but it does mean that we have to think a little bit differently about how we manage our settings, particularly a residential setting, and what does harm reduction look like in a residential setting. And another key outcome that we're going to be doing looking at in the new model is reviewing our priority groups to consider a bit more closely, perhaps about how the frameworks relate to the people and criminal justice clients in particular, who we do work with a lot. We're going to add that in as an additional group. So we're just going to explore a little bit further how our frameworks can guide practice for those people. And I think that it's over to Liz now.
Penny. Hi, everyone. Great to be able to join you and share our journey with you. So Penny's just talked a little bit about now that we're, at this point in the process, we know what's going to go in the new document. But of course, the next step for us is then actually saying, well, how do we ensure that we translate those findings into an implementation plan? We were able to identify through the evaluation the level of staff understanding, where there was confusion, what worked well and what didn't work so well. So we were able to identify where things were working really well, and what were the programs doing, how were they able to implement in a way or apply the principles and frameworks in a way that staff were able to grasp, make sense, and of course balance some of those different frameworks. So we were able to identify challenges and address them. So some of the challenges that we were able to identify was different levels of foundational knowledge. Different programs had staff all had different levels of training, and so some staff had previous exposure to a lot of those different principles and frameworks and had opportunities to do training. Others hadn't, and so I think it was a bigger change and a bigger learning curve for some programs. So we were able to then say, all right, well, what additional support and training do we need? And also at what levels? So making sure that we're addressing any knowledge gaps or skill gaps at all the different levels, from frontline to seniors to managers. We're also able to identify different levels of resourcing. As others have already said, we have quite a broad spectrum of program types, and all funded very differently, all in all sorts of locations. So some programs actually had specialist staff on board who were able to provide that extra level of expertise. And so we had some programs who were delivering their own masterclasses. And so they were able to address challenges perhaps much more effectively than some of the other programs that didn't have those resources. So now we're sort of looking at, well, how do we share that expertise statewide, but also nationally? We were also looking at the challenges of applying the practice manuals and guidelines in practice. We developed a number of practice guidelines over the years, which were designed to help staff understand how to apply those frameworks and principles in practice as they were addressing different issues. And some of those sort of bigger issues, for example, in residential settings, how to manage a lapse, and how do we ensure that we do that from a harm reduction framework, from a strengths-based framework, from trauma-informed, from recovery-oriented. And so we were able to review in what ways they were helpful, but also able to identify where some of the information wasn't pitched as practically as would have been helpful. So it was great to be able to get staff feedback on where they were sort of confused about how they would apply some of those frameworks in practice, and actually look at how we can add in, make them just that bit more practical. The evaluation also helped us understand the impact of the model of care, both through staff service delivery and also the participant experience. So we were able to identify what was staff saying about their own experience of delivering the model and the impact on their professional practice. So some had reported that they really enjoyed the fact that they could actually apply much more of their own clinical problem-solving, decision-making skills, whereas others had found it a bit, a bit more overwhelming. So we were also wanting to check, what kind of differences did we see in case management practices or delivery of groups, addressing behaviours of concern, but also in case notes. So we wanted to see on the ground how were staff able to sort of implement some of these frameworks, and so what was their feedback around that. and then how could we target our support a bit better. Also, was really helpful hearing how participants describe their experience. So we obviously have our own outcome data that we collect. But also I think the evaluation offered that opportunity to have an independent, independent group interviewing and to collect more of that qualitative, to hear quotes. So it was, for example, it was validating, really validating for us to read quotes that participants actually felt empowered and treated as an adult. So for us, that was like, oh yeah, that's the sort of thing. That's great. That's what we want to see. So that was kind of, we're on the right track. Next slide, please, Katie. The next phase is the implementation plan. So what is our strategy? So we have identified some areas for improvement. We have identified that we need to do some more work in terms of, I guess, getting that message across and communicating how those different frameworks integrate. So how do we ensure that there is that balance? How do we ensure that the messaging is that safety is really important, and that actually when you're trying to deliver trauma-informed care or person-centered care, that you're not actually putting, that doesn't actually mean putting other people at risk. So it was around sort of balancing. So we've learned a lot about that. Site risk profiling and safety planning as well. We have such different programs and different program types. So for example, with some of our residential programs, some of them are quite large and are on quite large properties, and others are much smaller and in more regional or city locations. So we want to ensure that we can support programs to actually assess what is their risk level capacity, and so that we're not, when we're actually applying some of these frameworks, that we are balancing that against risk and what the capacity is of the service to manage risk. Also, opportunity to review and update our practice guidelines to embed the frameworks and the model also into practice. And so some of the feedback that we had was that staff really wanted, more case studies. So they wanted to know in those really complex situations how they could apply that. So they wanted that bit more level of detail. So that's something that we know moving forward as we review our guidelines, is thinking actually from an extra level of practicality. We also learnt that we need to offer expanded learning opportunities. So we sort of talked about the case studies. We know that, again, some of the staff found it really helpful from the programs that developed their own masterclasses, that role plays. How do I manage this situation, and from the lens of these different frameworks. And we were also putting together a team we refer to as the dream team. So putting together those people who are experts in coaching and mentoring, who can facilitate some communities of practice. And we also were thinking about some of the feedback from staff was that they wanted a more in-depth training and support around supervision. So that's allowed us to sort of think moving forward, actually how we can target some of our supervision training using that model of care lens. So how do we ensure that our line managers actually know how to deliver effective supervision utilising those frameworks and principles. And then just lastly, review and update our treatment program for gaps and improve cultural safety and relevance. So it's good timing in terms of the feedback from the evaluation, because we're just about to start that process anyway of reviewing our treatment program, so we can look at, are there any gaps in terms of what do participants want more of? Where are the gaps? How can we present our materials in a more culturally safe and relevant way? So yeah, that's it from me. Thank you. I'll hand over to Catherine.
experiencing some tech difficulties, so I'll jump in here just to go through some of the key learnings of the process of such a co-designed implementation evaluation. As we've spoken about, the role of the steering committee was critical, and the steering committee met monthly through the life of the project. And lived experience voices were a really important part of that steering committee. So we had members of the steering committee with lived experience who looked over the surveys, the interview questions, and collaborated on the design of the implementation, evaluation, and the research questions. Of course, outside of those steering committee meetings, an open communication and a close working relationship was really paramount here. So particularly in terms of recruiting staff and participants from different types of states and services across the country, because we were aiming to get a representative sample so that different states and service types all had a voice in this implementation evaluation. Another key part of the process, and if any other organisations are looking at doing something like this with a research partner, is flexibility. So, for example, we workshopped recruitment as we went in terms of aiming to meet quotas for different states and services and participants, for example, in residential and non-residential services, to try and get a balance so all voices were heard, or as many voices as we could were represented in the evaluation. We also, had at the start of the process had sort of set ideas of what the outputs would look like in terms of a big final report. But through the process, as learnings from the triangulation of evidence became apparent, it meant that we designed together, we worked to design outputs that were best suited for different audiences. So, for example, a public short summary, the full final report, and then some appendices that were written for a management audience. We also learned that doing it right was, we wanted it done on time, of course, but our timelines did sort of edge out towards the end, particularly in the process of developing the outputs and the final report and short report, sort of due to the changing nature of how the findings that came out shaped our outputs. And yes, Mark, that's a great question. Any publications on the evaluations? We're collaborating those on at the moment. So we've earmarked 3 or 4 manuscripts that we'll be working on for publication in scientific journals and in AOD sector for AOD sector dissemination as well. Caitlin, you were a big part of. Oh, Catherine, hey.
I'm so sorry. I dropped out altogether just before my next bit. So thank you, Hannah. Have you
Was there anything I missed?
I don't know, because I dropped out.
There was nothing I missed then. No.
Excellent.
Did you have any, that was sort of, from my experience from leading the Deakin side, did you have any insights from the Salvation Army side?
Look, what I will say, and I'm not being paid to say this, is that Deakin were just so amazing to work with. The level of collaboration and flexibility was really good, and I think helped us get the best outcomes. So neither side were just, stuck like glue to our original concepts and timelines. We were both really committed to getting it done well rather than getting it done fast. And it was just a pleasure. Yeah. I'll let you keep going if you like, Hannah, because I'm just not sure or are we up to questions?
I think we might be up to Q&As now.
Oh, we were worried that we were going to have too much to say, but we must have all.
No, we're very efficient.
I think Caitlin has been responding to some of the questions as we've gone. So there's a number of answered questions in the Q&A section. But if anyone has any others for the chat or the Q&A, we're really happy to take them.
There's a question here from Elizabeth, who's asked about thoughts regarding delivering services to remote and rural settings where there's a lack of service coverage. And I know, Catherine, that the narrative literature reviews that we did on available best practice evidence is, there was a bit of emerging research there on sort of hybrid delivery models. Is that something that...
Yeah, it's actually a really big challenge for us in the service delivery space. Mainly, well, for a few reasons, but one being recruitment difficulties is probably our biggest issue. We have a couple of services in very remote areas, and then the other one is partner services, especially around withdrawal. You're having people with access withdrawal is really difficult, we find, in a number of remote locations. But one of this goes away a little bit from the evaluation, but probably our most successful remote one is in Alice Springs, where we partner with an Aboriginal organisation. They do the service delivery. We do all the reporting and other gaff. And so that emphasis on partnership has been what's really helped us there to deliver a service that's really, really shines, that one. I don't know if that answers the questions, but how was it built? Well, Hannah, I think the relationship probably goes back a very long way between Peter and Deb, doesn't it? So one of, she's not with us today, but Deborah Little, who leads our specialist team and is my right arm, had a very, very long-standing relationship with Professor Peter Miller, who works with Hannah, and they had done some collaborations at a service delivery level some years ago, and since then we have continued to work together in small ways over the decades. So it was a practical partnership and collaboration, but it was also a very human one, to be honest. One we're working around the sector, and we did ask for expressions of interest for organisations to do the evaluation, and there were a number of organisations that we had conversations with, but Deakin just seemed to be the one that fitted best, the one who understood what we were looking for best, and came up with a really...
You've frozen again, Catherine.
While Catherine's internet plays ball, I can talk a little bit about the continued collaboration between the organisations, if that would be helpful, Katie. So as Mark asked about sort of publications from the evaluation, we're collaborating on those in terms of co-authorship. So if anyone has any ideas of anything, what you'd like to know from the evaluation or the process, please let me know, because that may help inform some of our manuscripts. Where I'm also Peter, who Catherine spoke about before, along with our colleague, Dr. Georgiana Cameron, and I are supervising a clinical doctorate of psychology student, and we are piloting training for Salvation Army AOD staff on awareness of trauma, neurodiversity, and shame-aware practices. So we're in the piloting phase of that evaluation now, and we'll be conducting training with intervention sites in September. Hey, Catherine.
I am so sorry. I've just tried a different internet source, so...
This one's working well.
I wonder if I might jump in. I've just read through some of the earlier questions and just maybe wanted to add a couple of things. I can see there's a question there around the spiritual and faith-based parts of our program. And just wanted to add in there that we actually have developed a spiritual framework to help sort of guide particularly staff in sort of understanding what spirituality looks like and who has what role. So many of our programs have chaplains who actually do speak to more specifically, sort of spiritual counselling, that kind of thing. And they actually also deliver our spirituality program. The other thing, just to say in there too, is that we look at spirituality quite broadly, and so we don't force Christian beliefs on anyone. They're not that's not taught within that. So if people want to learn more or want to explore more, they have that opportunity through the chaplain or being linked to our other Salvation Army course. So within the program itself, we look at spirituality, but we look at it much more broadly, which does allow people of other faiths or who have a very different understanding of spirituality to think about their own spirituality. And so this is something that we have kind of looked at in terms of we don't want people to feel like something's being forced upon them, but it's an additional extra. So for those who faith is really helpful and important to them in their recovery, then we want to be able to offer support in that way. The other one I was just going to add to, Caitlin had already answered, but I just wanted to add in terms of the harm reduction component. So yes, particularly in residential environments, we need people to be substance free to be able to provide safe and effective treatment. However, what we have done is really adjusted our response to lapse, and recognising that lapse is quite often part of the journey for some people. So looking at how we can, instead of asking someone to leave, is looking at how we can actually work with people and give them that opportunity to continue in the program. Of course, that is weighing up against other aspects like the impact to other people in the program, that kind of thing. So we're also ensuring that the education, psychoeducation that people receive really does help prepare them for those situations, either during program or after program, where they might, or like things like safer using education, that kind of thing. So we just want to make sure that people are really informed. We also recognise that people will have different goals for their recovery. So we aren't saying to people, abstinence is the only way. We want to be able to understand what people's goals are and actually work effectively individually with them in looking at that person-centred. And so for some people, there might be more of a focus on the harm reduction, and for some people, there might be more of a focus on the different interventions that help them maintain abstinence.
Yeah, if I can just add to that, because the dealing with lapse one under our model of care has been possibly the most challenging to deal with, and there's been some very strong views both by staff and service participants. But our guidance says, and there's more coming in writing, Penny is also answering that question in writing, our guidance says we do not discharge people for lapsing ever. We may discharge them for issues of safety around lapsing. So our approach is always to try and tailor support more, to use lapse as a learning experience. But we do recognise that sometimes when you're keeping a whole community safe, where many people are trying to maintain abstinence, it's incompatible to keep someone for the benefit of the greater community. In that case, our practice guidance speaks very strongly to the need to remain engaged with the person, refer, safety plan, provide harm reduction resources and information, and do everything we possibly can, because it's the opposite to harm minimisation, isn't it? When you just kick someone out because they're showing that they're in need of greater support, and we don't want to do that. We want to avoid that wherever we can, and when we can't avoid it, we really try and pack a lot of supports around it. will there be more focus on aftercare in the new model of care? We'd love there to be. I think money is the question there. It's unfortunately the bottom up line, but we are actually exploring a number of ways to increase the levels of aftercare currently.
I think the addition of delivering smart recovery is actually one of the ways that we're helping fill that aftercare gap. So we're delivering those online smart groups that anyone nationally can join in on, and so that's sort of helping with that kind of bridge. I think the other thing is we're quite fortunate. We have a variety of service types. So we actually have community-based services, and we actually are in the process of really trying to expand on our community offerings so that so not only for people who maybe residential isn't actually a great or suitable option, but also for those who want to continue accessing support while in the community. So we have sort of great opportunities so that we can actually start offering more in that community space and in different ways. Like we said, being able to offer online groups, online smart groups nationally, so that it doesn't matter where you are, that you could, as long as you can access the internet, you could attend.
And just to jump in there from a research side of things, follow-up of service participants who then exit the services or leave the services after their treatment. It's notoriously difficult to follow up with service participants once they sort of leave the service, and so that's something that we're also working on as a sector-wide focus on the research side as well, because those follow-ups over time, that longitudinal information from service or ex-service participants is really important as well to measure treatment outcomes and treatment journeys, because we know that's not a linear process.
I just noticed there's a question there from Margaret. What if a person is on an MMP? I'm not sure what you mean, or if that's already been answered. Metronome program. Yes. So actually, yeah, again, our programs have been able to adapt and be able to offer more options for people who are on different kinds of pharmacotherapy. So, and this is one area in particular for our criminal justice clients, those who are coming from prison settings, who are on injectable bupe while they're in prison. So we've been able to establish some really good prescribing and dosing relationships in the community. So that's been a lot of hard work, but we have been able to do that. And so that's, and again, it does also depend on location, as some of our programs are sort of out the back of nowhere. And so sometimes ensuring that we can actually ensure that the dosing can continue can be a challenge. But then some of our programs are in city-based locations. So again, having a national model or having a few different services across states that we can actually be flexible and recommend particular sites of service might be more helpful for others. We certainly don't want that to be a barrier. So we are, I think, consciously trying to make sure that we are addressing barriers. We want to be able to take people who are finding it the most difficult to access treatment. So where we can work through those barriers, we are trying to do that.
Beautiful. Well, we have about 5 minutes left, and I would love to hear from each of our panelists to help kind of wrap up, maybe providing to people working in community organizations what your key takeaway or key piece of advice is for people wanting to translate research or evaluation findings into practice. if you feel comfortable to share that as your key takeaway.
I'll go first, if that's all right. I'll jump in. I think from the research side of things, Katie, I think it was one of the key things was working with a multidisciplinary team. So we had experts in implementation science, in AOD policy, in harm reduction. Then we had input from lived experience and people working in the AOD sector. So that I think is key to translatable, practical recommendations that can then be implemented and evaluated. And for any community service organisations who are keen to translate practice into research in terms of evaluations of what they're doing, I would, if you don't have partnerships with researchers or academics, I'd just recommend you to look them up and email them. And because, you know, we're really keen to evaluate and use our research skills to help the community.
Thanks, Hannah. Liz?
Can I just say, I think for what I've just found really valuable is it's just wonderful to actually ensure that we get all different perspectives, that we listen to people. And I think, you know, it's challenging having such a large organisation trying to operate nationally and have all these different levels, but trying different ways to do that so that we can ensure that we are listening to people on the front line, that we're making sure that the different support documents that come out actually are answering the questions that people have. So I think, yeah, I just really recommend that.
Such a great point, Liz. Thank you. Catherine, have you got anything to share?
Yeah, I would just encourage both sides of the equation to be brave. You know, it's great exercise in itself, entering into academic partnerships, but the brave bit is actually implementing it and making sure that what you learn changes what happens face to face with the client. It's my bit.
Beautiful. Thank you, Catherine. And Caitlin or Penny, have either of you got any insights or tips to share?
Yes, have lots of time. Lots of time. I think Catherine said it. Do it slow, rather, you know, just get it right, do it right. And if you're wondering how I managed to get through over 80 recommendations, Copilot is your friend if you want to help sort them out.
Yes, a great point, Penny, of utilising our AI for good. Absolutely. And Caitlin, do you have anything to share?
Mine was just about echoing Liz's sentiment of making sure lots of voices are included in the process, because you can be surprised about what you hear sometimes in different. You need to include everyone in the process. Oh, can't hear me.
Oh, Caitlin, your mic's a little bit funny, but I think I could hear you. It's about like you might be surprised by what you find as well. And so I really like kind of hearing the surprising takeaways and how you guys are implementing that into your model of care as well, and for kind of future implementation too. So look, it's 2 o'clock on the dot, and I just want to thank Caitlin, Hannah, Catherine, Liz, and Penny so much for your time and for your expertise. I learned a lot. It was so great to see everyone so engaged in the Q&A and the chat throughout as well. So thank you all for participating so beautifully. If there were any questions that we weren't able to get to, I'm sure we'll try and acknowledge them in some way. And yes, we will be sharing the slides with you as well as a follow-up to help kind of support your ongoing learning. And we'll also be popping the recording on the ComDone website as well, so then you can share it with your networks. You can revisit it if you've got anything that you really want to take away from the session. So look, thank you so much, everyone. A short survey will pop up just to grab your feedback and let us know what we're doing well, what you'd like to see more of in the future. And look, I just thank our presenters again so much, and I hope to see you all at another ComDan event soon. Thank you so much, team. Appreciate you.
Thanks, Katie.